And we're back for round two with Ben Cormack. Ben, it's been a few years since you've been on. The first episode was, if people want to go back and listen to it, episode 48 on the conversation around flexible interactions and communication as a whole. For people who may have not heard that first episode or just aren't familiar with you, can you just give a little intro on yourself and what you do?
Yeah, so look, thanks for inviting me back. I haven't had a second date for a while. I've been married for like 18 years, so obviously my wife would get upset if I had another second date. But so yeah, my name is Ben. What do I do these days? So I would mainly regard myself these days as more in the education space than the clinical space, mostly because I'm quite old and a bit tired these days, and it's much easier. And I'm much better at being an educator than I ever was being a clinician. So I run a company called Core Kinetic, which looks at providing education around movement and pain and research and all of these type of things that we can then use clinically. Many years ago, my original degree was in something called sports therapy, which is MSK based in the UK. I do a little bit of clinical work still, and I enjoy it much more now than I did for a long period of my career when I used to get up and do sessions at 7 a.m. and get in at 10 o'clock at night, and it all felt like very hard work. So yeah, I also do some writing stuff. So I enjoy doing a little bit of academic writing, and I like to see some of that stuff published every now and again. I don't always do a lot of it, but I like it to be impactful when I do it. And, I get around the world teaching, doing conferences and just meeting fantastic people, having good conversations and some beer and wine and some good stuff.
I'm sure that was a bit tongue in cheek of being a better educator than clinician, but I'm sure some of that is true. Do you have a reason, or have you reflected as to why maybe you've leaned more towards the education route at this point in your career?
Yeah, I don't know if I've particularly reflected. Reflection can be dangerous. It can lead you to some dangerous places. That, again, of course, is a joke. So, no, I think what I like about my career at the moment is diversity. So I think that any time in your career you end up just doing one thing all the time, whether that's clinical stuff, etc. For me, I don't know if I enjoyed that as much as having a bit of variety and a bit of diversity in what I do. And I, certainly think that, my enjoyment at the moment tends to be more in the teaching realm and than the clinical realm, I would say. Although, as I said before, the more I do clinically these days, actually, the more I enjoy it. Probably because I don't do so much of it.
Well, the topic for today is going to be on patient education. And let's start with if there is actually a definition for patient education, and then we'll go straight into, after that, what does the research suggest? Ben, you had mentioned that you'd pulled or looked into the literature on some of the research around patient education, and we can start wherever you want with what you were diving into.
Yeah, so it's a great question about the standardization element. So if you were to pick up guidelines around back pain, let's say acute back pain, whether that's the NICE guidelines or, the recent Lancet series, etc. One of the key things that will be mentioned is the idea of patient education, reassurance, these type of things. In fact, they are our primary treatments for acute back pain. So, forget manual therapy, forget exercise, forget all of these other things. Actually the guideline recommended stuff is based more around our interactions with people rather than actually treating pain. Because at the moment, unfortunately, the efficacy of the treatments that we have for acute back pain, for example, are not much to write home about. So, so first thing is that this is something that's quite ubiquitous. But for something quite ubiquitous, it doesn't seem like there is a massive amount of definition or standardization about what constitutes education or constitutes reassurance. which I find fascinating. In fact, I'm not actually sure I particularly like the terminology education, because I think it kind of implies this element of, teacher pupil relationship. And I'm not entirely sure that's always hugely a power dynamic that I think I like clinically. And I think works when you get two people together. Generally, a power dynamic doesn't work very well in that kind of sense. So I have a little terminology that I use, and I'm not entirely sure whether it's an element of academic masturbation in some ways, but I use this term knowledge coaching. Because I think really what I'm trying to get to with someone is an element of a shared understanding. So can I help this person understand their problem better? So am I educating them? I don't know if that's particularly what I would describe it as, because I think it needs to be a bit more of a two-way street. But certainly I'm providing an element of information, an element of understanding, an element of making sense. And I think we need to think of that as a two-way scenario rather than a one-way scenario, rather than kind of a teacher pupil relationship.
Yeah, and maybe, if you asked a variety of students in a variety of education settings, what does a teacher or educator mean to them? I would maybe guess that what they would describe as some really good teachers is there is more of that flexible dynamic and not that hierarchical approach. And it is more of a back and forth. So it could also be just how people perceive it. And like you said, maybe a lot of times the perception is that it is just this kind of top-down, one-way interaction.
Yeah, and there is nothing like a power imbalance to ruin a connection. If you want to ruin a connection, create a power imbalance. And I think that's always been a little bit of the problem of healthcare, hasn't it? Going in to see, the man in the white coat, he's in charge. He's just going to speak at you. He's going to tell you what's what. And then what do most people come away and say? No one listened to me. No one connected with me. And that's the kind of classic element of healthcare when we go round in that circle. So firstly, I think, that the point is maybe to move away from the idea of education and a little bit more to that kind of, what we were just talking about. But the bottom line here is patients, when they come to see us, they want information about their condition. In fact, I would say one of the primary reasons people come to see a healthcare professional is because they're worried about what their problem might be. It hurts. I'm scared. I'm worried. I'm apprehensive. Am I going to make it worse? And, the point there is, how can I help that person through information? And I think that's supremely important. And in fact, I remember presenting at the San Diego Pain Summit maybe 5 or 6 years ago. And I was talking a little bit about patient-centered care. And someone said to me, but, what does the evidence say about that? And in a way, does it matter what the evidence says about education or information? Even if it didn't change pain, even if it didn't change disability, is it still something that's worth doing to have an effect on the person? And so almost, is there an element of, how much does the research matter in that sense? Even if it didn't show this big, amazing effect, which nothing shows a big, amazing effect, because that's not how research is designed. But, this idea that, when we look, that it has to give us this kind of, if it doesn't affect pain by 2 points on a 10-point scale, then it's useless. Well, if a patient feels that they've had a good interaction, they've been heard, they've got some information, they've made sense of their problem, then almost to some degree, I don't care whether that shows any reduction in pain or any reduction in disability, because that's treating the person or interacting with the person. And that's something that we miss sometimes if we quantify everything from a research perspective. But if you want some good news, when we do look and test educational interventions, we generally do that alongside other forms of intervention, whether that's exercise or whatever, we do see actually that education on its own seems to be as powerful as some of the interventions that we use, such as exercise, which is fascinating. So,
yeah, a follow-up I have there, and maybe you were going to go into it, but there is frustrations or concerns about when exercise is discussed in the literature. There's so much heterogeneity, and sometimes that's valuable because a lot of exercises and models can provide value and there's freedom there, but also it's hard to standardize. And that may be similar to when they are looking at patient education. So if you're diving into the research and you're reading that patient education was provided, is there some level of a streamline as to what that means, maybe in these low back pain guidelines or these other consensus groups as to when that is a treatment or when that's recommended? Do they actually define or discuss what actually that education means and is?
well, let's take the recent Restore trial, the CFT trial that just came out in 2024. So, as far as I'm aware, the education that they used or the interaction that they used isn't particularly standardized. So I think it's very, very much patient focused. It's listening to the person, understanding their story, understanding their concerns, their worries, their interests, and then being able to interact with that and answer questions based on that, etc. And in the Restore trial, they showed that, there was a reasonable reduction in pain. Pain wasn't the primary outcome measure. I think disability was the primary outcome measure in the Restore trial, but they did have pain as an outcome measure, and I think they reduced it from something like 6 down to 4. And we have to remember these are people with an average length of pain in many, many months, going into years. So from that sense, they didn't standardize it. But when you look at pain neuroscience education trials, they very much standardize it. So they'll put people in a classroom, they'll use a bunch of metaphors, or they'll use, some basic pain science or pain neuroscience or whatever. And it's interesting when we look at pain neuroscience education delivered in a much more standardized way, actually it shows much less effect.
And would your assumption be because it's not centered and tailored towards the patient and there's less salience that they're perceiving that information? Or do you have any other rationale or thoughts as to why maybe it's a little bit less significant?
Well, I think completely that we come to a physio or whoever else and we have a set of concerns and worries. We have our own individual. Look, let's take an example I had the other day. I was working with someone with lower back pain. The question that they really wanted to know from me that we got to at the end and we went all around the houses was, is it okay if I dance at my sister's wedding? Is this going to make my problem worse? Right? So when you standardize education and I tell you about your neurons and I tell you about your nociceptors and I tell you about nociplastic pain and all this other things that most people don't really care about, is that it's almost like taking a bunch of mud, throwing it against the wall and hoping some of it sticks. And I think that's the point, is that the more we standardize, the less we are probably providing information and education that is going to resonate with that person in front of us. So it doesn't mean that I can't have a stock of metaphors or I can't have knowledge about things. But it's very, very difficult to take a bunch of information and just give it to everyone and everyone interprets it in the same way and it has the same kind of therapeutic effect. When people have different concerns, different worries, different lives, different occupations, different sports, and it's almost nonsensical to think that that we can standardize it in that way. But having said that, are there some areas in which we can, I think, provide education that does encompass to some degree what people want to know? And Louis Gifford talked about this. he talked about this idea of, how long is it going to take? And if you look at the Lynn paper, 2019, there are a bunch of Australian research. I think Steve Camper's in there and a few other people. They did a paper on what do patients want to know. And they want to know, how long am I going to have this problem? What are some of the things that are going to affect this problem? And we would call that prognosis. What are the best treatments for this problem? What can I do to help myself? What are self-management strategies? So I think that education should often relate generally to people, and self-management strategies can be general. But then also, do we need to some degree, personalize those basic self-management strategies? So we can have basic information that we use, but I do think the magic does happen when we just give it that little twist of personalization, when that person feels like this is for them. This takes into account their life, their problems. So I think that's quite powerful. So if we look at some recent papers, what was there? There was the Dube paper, really, really well done RCT, looking at subacromial pain. And they were a bunch of French-Canadian guys, I think. Yes, I'm pretty sure they're French-Canadian. And what they wanted to know was they had 3 different groups. One group was education on its own. Another group was education and kind of motor control exercises. And another group was education and strength exercises. Right. And they actually did it quite well in terms of the exercises. It wasn't just strengthening. They did some, testing, and then they did some appropriate progressions and these type of things. And the 2 exercise groups didn't outperform just the education on its own. Right. And we could say there isn't a 4th group, which is natural history. So can we kind of tease apart whether it would have been better than just time alone? And the answer to that question would be no. But let's have a think about what some of the education that they talked about. So they talked about making sure that you had comfortable postures. So if you're spending any time in prolonged postures that hurt, try not to do that. Some fairly decent common sense. They talked about relaxation and breathing techniques to kind of get that parasympathetic system going. They talked about general health. So doing adequate amount of exercise, in terms of the kind of WHO guidelines, that type of thing. They talked about sleep. Again, trying to get some of that systemic type of stuff sorted to some degree. And then they also gave parameters around pain and activity. So they talked about if you do an activity, don't allow it to flare your shoulder up more than 4 out of 10 or 3 out of 10. I can't remember exactly the number that they used. So this is interesting because we talk about education a lot and it tends to be centered around, pain education would be the great example, the nuts and bolts of the pain system, and the pain philosophers will come for me for using that terminology, and that's fine. I'm used to it. But what you see from I think from really good education is it's quite pragmatic. It's not very conceptual. It's not about pain is an alarm or all this other kind of stuff. It's actually, if it hurts 10 out of 10, probably you shouldn't do that. Right? Or, if you're not getting enough sleep and you're feeling tired and that can have an effect on MSK pain, then you should probably get a bit more sleep. And you should look after your ecosystem, So that was one paper, and that's what they saw there. Now there was another paper, which is my favourite paper. I don't know if that makes me sound like a bit of a nerd or a geek. Do you have a favourite paper, Chris?
I don't think I do. It's probably recency bias, especially when I was in grad school. Everything I read felt the most impactful. I think I have more favorite authors or certain books. I'm glad you brought up Louis Gifford. I unfortunately just found out about him about 6 months ago, but that's a phenomenal series of books, and that would classify as a favorite set of things. But paper itself at this point, I don't think so.
No, and that makes me feel really nerdy and geeky, and maybe I'm going to have to reevaluate who I am as a person, and I don't know. But this paper here is looking at patellofemoral pain. It's Alexandra Hott. I think they are a Danish group, but I may be completely wrong. And I apologise to Danish people at large. But they again had three groups. They had a knee exercise group because knee exercise can help knee pain. They had a hip exercise group because hip exercise can help knee pain. And then they just had a control group, which they called free activity, which is just like, go and do what you want as long as you stay within the education. So all three groups also got education. So they did this really nicely. The one point that they gave was that PFP is benign in the sense that it's not something dangerous, it's not something harmful. They described it as loading pain. So they're conceptualizing and making sense of patellofemoral pain by suggesting it's not, we haven't got this tissue thing that we can find. It's a diagnosis of exclusion, etc. So they're trying to kind of de-emphasize that injury, pain, damage. And that actually comes from a Norwegian model, a guy called Arj Indal. Back in 95, I think he published. And just to give you a bit of reference, I left high school in 95. Which makes me feel quite dramatically old now I think about it. But he had something called the non-injury model. And the idea of the non-injury model was to give information and education about back pain. And the idea was to say that back pain isn't dangerous. Back pain is loading pain. It's generally movement evoked. We can't find a source for it. It's benign as a thing. And just trying to de-emphasize the threatening nature of a diagnosis. So rather than saying, oh my God, you've got a slip disc, your back's going to fall out, your nerves are on fire, you're going to die, they're trying to do the opposite and say, you know what, this is something that comes and it goes, it's mostly loading or movement evoked, we can't find a specific tissue, but you know what, movement really helps. So Indal actually, his education centered around the idea that the worst thing to do was be careful. This is back in the 90s. The worst thing to do is be careful. And if you contrast that with the information we give people today, if you come out of neutral spine, you will die, your family will die, the world will implode, right? And it's fascinating, but you can see why it didn't catch on. Because it's not great for healthcare systems, because it's really difficult to sell that. So going back to the Hott paper, they received education about what patellofemoral pain is, loading pain, no pathology we can find, etc. And then they were also encouraged to gradually increase physical load without excessively provoking knee pain. So that's why the free activity group is such a genius. So go and do whatever you want as long as you don't massively flare up your knee. And the free activity group actually did the best out of all.
Yeah, that probably helps a ton with having patients continue to come in with specific answers about what I can and can't do. If you provide that upfront expectation that I'm open to whatever you want to do, as long as we've set these parameters of what is appropriate or safe, or we feel like we're in a comfortable range. Again, do you think that that group improved faster or had better outcomes because they were able to do more of what they enjoyed as opposed to these kind of more rigid recommendations?
Yeah, the differences weren't huge, but it shows that probably the most powerful part of all of the three groups was the educational component. That actually the movement intervention probably didn't need to be that specific. And that's the kind of what I get from that research. And we argue over, is this the best exercise? Is that the best exercise? So a key factor I would like any patient coming away from me with is a parameter of safety or a parameter of tolerance, whereby they can come away and they don't have to say, Ben, can I swim? Can I cycle? Can I do this? Can I do that? No, they've got the knowledge. Everything is okay as long as it fits within this parameter of your stimulus and response scale. And I think that is hugely empowering for people to have. You know, it's like I've got, this is the definition of self-efficacy, isn't it? You know, is that I feel like I can do this because I have this knowledge. I don't need to defer to Chris. I don't need to defer to Ben. I don't need to ask, is it okay if I do this? You know, is this dangerous, etc. No, we're going to do this based on your individual stimulus and response pattern. These are our parameters. That's self-management, and I think that breeds self-efficacy.
Yeah, I think you've touched on a lot of the big rocks with successful patient education of providing reassurance with a lot of these cases, providing maybe an average prognosis or a timeline of how long this may take. And then, like you said, providing these parameters of safety or this bandwidth of what is okay to work within. And then other things may include, as you mentioned, what are our treatment options? What happens if you do nothing? And then maybe what is the recurrence rate? Like, let's be okay with knowing that this may come back in the future, but we have these similar recommendations if it does come back. I think those are really big hitters, and they're all pragmatic and practical, and they don't go into the nitty gritty of the mechanistic explanations behind pain or behind the injury, and it's not salient to the patient.
Yeah, and I think one of the big problems is education has become synonymous with this kind of pain mechanistic biological shit. I don't know whether I'm allowed to say that or not, so I apologise. I'll see a SWAT team come through my window and take me away. I don't know. But I think education has become synonymous with pain mechanisms. And I think that's a really, really big problem. I think most people want pragmatic information and knowledge to manage their problem and make sense of their problem. And if you can do that, I think that all of the other stuff maybe isn't that specific. It's a great example. So there was the JF Escalier paper, the patellofemoral pain paper as well. Again, JF, he's another French Canadian, right? I don't know what it is with those guys and good research, but you know, there's some good stuff going on. So big up the French Canadian crew. And they did a paper using education, and they educated about load management. They gave a parameter for pain, so you're running is okay as long as you stay within this kind of parameter. And they had three groups. One was gait retraining, because gait retraining is shown to have an effect on PFP. They had exercise, because exercise is shown to have an effect on PFP. And they just had an education group as well. Guess what? The education group on its own was as good as doing all the other stuff. You know, so if people say, does education help? Again, what we haven't seen is education versus no education. I don't know why. Maybe there's not enough value in that. And we rarely see four groups within a trial, because that's just probably mind-blowing for everyone involved, costly, etc. But when we put education up against other interventions that we talk about, it seems that education on its own has as much power as any of these other things. Which to me, it makes total sense, because, you know, maybe education is about helping people reduce anxiety, helping people reduce worry, catastrophizing, etc. And ultimately, I think that can often lead to positive behavior change. And ultimately, that's the problem. Is education a tick box exercise, or are we making people emotionally feel better, or changing behavior to make them feel better in another way?
And the examples you've provided have been low back pain. You mentioned like rotator cuff related shoulder pain or subacromial pain, and then patellofemoral pain. People may say, well, all those, they kind of like generally go away on their own. What about these postoperative surgical cases, like an ACL reconstruction or something a little bit more high risk, like a high risk site stress fracture? I would say that education is even more or just as valuable for those. Yeah. And it's still the same thing. It's providing a prognosis of how long this may take, maybe a little bit more narrow bandwidth of what you're able to do at this point in time based off of these kind of current status of the tissues, and what is acceptable to be within, and how do we go from these progressions moving forward. And it's regardless of the condition, it's extremely valuable. But it may be a little bit tighter parameters of safety for these higher risk or more tissue sensitive conditions or injuries.
Well, take the BSI, right? So we'd probably be educating on elements of training error, loading errors, right? So that would probably be one of the first things that we talked about. So we could educate on that. We could probably educate on the idea that, you know, pain is not weakness leaving the body. That's your stress fracture just getting worse. We could educate around nutrition. We can educate around proper recovery. We can educate around timeline. We might tighten the parameter of what would be acceptable pain. I probably don't want a 5 out of 10 with a BSI, you know, whereas if I have a tendon or I have a lower back pain, maybe I can creep up a little higher on that kind of painful parameter that's okay. You know, maybe with a BSI, we're going to say, yeah, let's bring that down. You know, again, with an ACL, we're going to say, you know, there's a timeline here. You know, what would be some good evidence there? So every month after 8 months or 6 months or whatever, your risk of re-injury, you know, dramatically reduces. And again, that's really important because how many people want accelerated recovery or accelerated rehab and don't understand that there might be a risk associated with that? Again, and that's very powerful because people get frustrated, they get upset, they get annoyed. I want to get back to playing. And there's other people out there that are going to promise them everything. You know, as long as you have this injection or you have this or you have that, we're going to get you back in 3 months. You know, where someone needs to come along with good information that helps them make sense of it, helps them reconcile that, make sense of it within their mind and say, you know what, we're going to calm down, we're going to be in it for the long haul and we're going to do the good stuff.
Switching gears somewhat to what are things that maybe we want to steer away from in regards to these interactions. And this information can be very useful for a new grad or a student on clinical rotations where there's just not a lot of experience and reps and maybe less understanding of the literature on these conditions, and they make common mistakes that are just kind of the reality. Can you touch on maybe, and you already did, some of these mistakes when it comes to educating or sense making with a patient? You've already mentioned this overly kind of pathological or mechanistic pain neuroscience education that a student may like really latch onto in school because maybe their professor does research in that area and that's what they are now using with their patients during clinical rotations. Can you touch on some other common mistakes that newer clinicians or students make when trying to reassure or trying to educate, but it's maybe falling flat?
Yeah, and I would say the biggest thing here in any transfer of information is it's about building trust and connection. The information doesn't just go into a vacuum, right? So I've been reading a book called Super Communicators by Charles, I've forgotten his surname. It starts with a D and I don't want to embarrass him or me by trying to pronounce it. What was fascinating to me about this idea of communication is this element of connection, emotion, trust, respect that actually is about communication. So, you know, and again, there's that famous, I think it's Maya Angelou, isn't it? That, you know, people don't, which is the Maya? Oh, my brain has gone here, Chris. But there's the quote, people don't, you
got it,
my
Ben.
brain is gone. People
That's okay.
don't care how much you know until they know how much you care. And I don't think that is Maya Angelou, but I think that's someone else. And I think that's one of the big things that we get wrong, is we think that information is just going into this neutral zone where everyone is, you know, it's switched on to it, etc. The big thing here is that before we give people information, before we help them make sense, there has to be an element of connection. That, you know, I think that probably helps all areas of treatment. You know, behavior change probably relies to some degree on connection. Education relies to some degree on connection. that we are actually interacting with someone. We are, showing them respect, that we're showing them we're listening, we're able to interact with the information that they give us. And after that, we may then say, there's some really good information that I think will help you understand this problem a little better, right? Rather than just being like vomiting science at people, or vomiting mechanisms, or vomiting research, or whatever else. Actually, the biggest thing, the mistake we make, is we jump into it, and it's not a neutral event. It's not something that is not with meaning. And if you can get some meaning and get some connection, these type of things resonate better, much, much better. And I think that's the big mistake that we can make in rehab in general, is expecting someone just to take what we have to say or what we have to do, and without any kind of interaction or connection, just kind of accept it and act on it. And how many of us are not very good at listening and changing our behaviours? But we expect that, don't we, from our patients? So before we give information, I think the information has to be relevant to them, not to us. It has to be less about my knowledge and my ego, and I think it has to be preceded by an element of connection, trust, respect. And I think that's to some degree the point of things like active listening, is that, one of the great things that people want in any walk of life is to be respected and to be listened to, given that time and that respect, whether it's in the bar, whether it's in a shop, whether it's in physical therapy, wherever. That's what we want. And I think we are becoming less like that as a society, where we actually show each other basic eye contact, connection. What do people do now? Generally, I saw this. I can't remember where I was the other day, but there was just a family of people just sitting around, everyone looking at their phones. There was zero connection there. And I can imagine if someone gave information to another person, they probably wouldn't even take any notice. So I think that good information has to be coupled with good interaction and good communication. And that starts off with basically being interested, basically showing someone else respect. And I don't know if I touched on that before. That's the point of active listening, is to show you are listening and make the person feel heard. If they don't feel heard, all of the information that you're going to give them after that probably doesn't matter very much.
I think every clinician has moments where they reflect back on and just think about a lot because they didn't go well. But are you able to provide kind of a personal story of a time at all in your career where this interaction just didn't go well, and why, looking back, that might have been the case, or what reasons that could have led to a maybe unhelpful interaction?
I think when two people are not on the same page, generally we get poor interactions. So you get someone come in and they want to tell you about their experiences and their problems and these type of things. And really what they want from this communication is to be able to express themselves, to be able to talk about their concerns and talk about their worries. That's part of what they want from their conversation, whether they realise this consciously or not, right? And they just want to be heard. And then I turn around and just give them a solution. Or I turn around and, say, that's brilliant. Why don't you lie down while I rub you now? Do you see what I mean? Or someone else comes in and they want information and they want a solution. And you go, well, why don't you just keep on talking? Why don't you tell me about your feelings? Right? And I think often when it doesn't go well, it's when two people want two different things out of that interaction, right? So classic example would be me and my wife. She wants to tell me about her problems. I want to provide a solution, right? And that would be the classic, wouldn't it? The classic marriage one, whereby, sometimes all you want to do is verbalize what you're feeling. And then someone provides a solution and you're a bit like, well, I didn't actually want a solution to this problem. I just wanted to talk about it. So I think probably not recognizing what people wanted from me, not being able to say, not not wanting at the end to provide this solution whereby that person goes, oh my God, this is amazing. This is, there's the great Louis Gifford quote where he says, the person after pain education who got up and rode their bike after 5 years just doesn't exist. Because I want to hit that home run. I want to give that metaphor that changes that person's life. And actually, that person just wanted to tell me about their life. It wasn't that they wanted particularly this grand solution or metaphor. They just wanted to be able to externalize and verbalize some of the things that they're feeling. There isn't a solution to that. There's just an externalization, really. So probably not realizing it's two-way. And then just giving people information that I thought was going to explode and change the world. And the amount of times that I've done that with pain science is probably incalculable. I'm not going to give the money back because I'd be really poor and I wouldn't be able to feed my kids and stuff. But yeah, you look back and you think, I probably could have done better in quite a few situations if I understood communication a bit better. However, one of the amazing things about communication is sometimes it's a slow grower, right? And you learn more about it the older you get.
You mentioning some of those comments made me think about the patients where you pull them from the lobby and even before you sit down, they just start talking and you realize this whole evaluation is just going to be them elaborating on whatever it is. And that's the most meaningful and powerful thing that you can do is just listen. And if they have questions, provide input and do whatever you feel like you need to do to at least have a competent exam before they leave. And then there's the other people that walk in where they're one answer or one, word answers. You try to provide open-ended questions and you realize that this is going to be a much different interaction than the person that didn't stop talking for an hour. And there's nothing inherently wrong with those two ends of the spectrum, but you have to be aware of how your body language, your communication, what you say and don't say changes in those scenarios.
Awareness is the key. And I've learned this, I think, through educating as well. Again, education is probably the wrong terminology because I really appreciate the two-way element of it. But just being aware of being on the same page as the person that you're working with. And sometimes we see educating as just a piece of information. It's not. It's not just a piece, or if you treat it as a piece of information, you're probably not going to get what you want from it. It's about, it has to be woven into a good interaction that works with two people on the same page. Look, I'm going to be honest, there are a lot of people out there that are horrible communicators, right? That's just the way of the world. But they're not paid to communicate. They're not paid to do what we do, are they? Do you see what I mean? It's not on them to be great at communication and recognize these things and work. It's on them to do their jobs. Otherwise, why are we being paid for this? It's on us to say communication is a key part, information and education is a key part. And if I can get on a similar place to the person that I'm working with, that transfer of information is going to be more powerful.
There are going to be scenarios where the interactions just feel clunky for whatever reasons. And you're realizing that this isn't going as well as it could. Do you have any recommendations for clinicians or students that you almost want to bring up the elephant in the room and maybe reorient and say, in whatever aspects, I feel like we're on a different wavelength or a different page. Can we kind of reset? And this is my understanding. You tell me what you're trying to get out of this interaction. Do you have any recommendations as how to kind of reset an interaction when it's going poorly?
Yeah, well, I think the first thing about being a reasonable educator, communicator, interactor, whatever, and that's kind of, we've talked about the information side, now we're talking about the other side, is to recognize when things are going to shit. Right? And how many people, both sides don't recognize this and it's just descending, right? And I think the first thing is to say, okay, this isn't going where I want it to go. And can you try and steer it back in a different way? We could say, well, why don't we talk about this? Or is there anything you need to know from me? Or, is there any questions that that I haven't answered, or, just trying to get something from someone. But I think the first thing is that awareness, to be able to just recognise that this maybe isn't going where it could go. But how many people have horrible first dates? Right. Sometimes you just have to realise that two people don't actually communicate that well, or this person doesn't communicate that well, and we just have to make the best of a bad job. Maybe I'm having a bad day, you're having a bad day. And I think that the biggest thing we can do is not become reactionary, because I think it's easy to, meet aggression with aggression, or meet frustration with frustration, or being pissed off with being pissed off. And, I think that it's our job to remain a little bit more cognizant of the scenario, who we are, where we are, and what we're trying to do. But if you felt the need to come back and say, buddy, did we get off on the wrong foot? Then if you feel that you need that reset, then that's a brave thing to do, and I would applaud that. And that could really work in some scenarios.
The other example is, or idea during those interactions, is being aware enough to realize that you may not be the appropriate clinician for them. And there's times in clinic where there are these younger, elementary school females that, as as comforting and as nice and as sweet as I could be, they're just obviously more comfortable working with female clinicians. And there were multiple scenarios where they transferred care to a female provider, and the interaction with the young girl, the mother, they were just smoother because of those contexts. And being aware enough as a provider to know, for XYZ reasons, this individual or these other clinicians make more sense. And I'm going to be open and transparent. And that, even though you're not the right fit, the patient or family may be extremely appreciative, even though you're not going to be their primary provider or primary therapist.
Yeah, I probably wouldn't do that I wouldn't probably subgroup or select that. But I do think there are times when, that you are then where a female may feel more comfortable with a female, or a male may be more comfortable with a male. For a whole, for societal reasons, or things that we don't know about in people's pasts, etc., etc. There's class reasons, religion reasons, race reasons, gender reasons, isn't there? And I don't think we can make assumptions and subgroup and these type of things. But, sometimes having the kahunas to say, maybe someone else might do a better job, you have to applaud that. Although I suppose the dangerous side of that is the classic, oh, this is a difficult patient, why don't you take them? Right. So, how many times have you heard that, oh my God, we've got so-and-so coming in, God blimey, they're a bit difficult, or that type of stuff. And I think sometimes that's a way of avoiding changing our communication style or our information style away from, I would always say, let's give it a go first, and then say, yeah, you might like this person. They've got a lot of skills that I don't have.
Yeah, I appreciate you providing that caveat and not clumping. The clinic that I initially was at outside of grad school, it was very common for us to co-treat, and it was like a very stark difference between certain patients when they would interact with me versus the other co-treating provider, and noticing that. And that's kind of an easier transition of care, and also bringing it up with the patient. Would you prefer? But it doesn't have to be just because of XYZ reasons. It's seeing those trends over time and then making that gentle recommendation if it feels appropriate.
Yeah, absolutely. I agree with that, sir.
Is there anything else from either any research papers you wanted to discuss, or any other things you wanted to comment on in regards to patient interaction or patient education that we haven't touched on, Ben?
Yeah, I think the biggest thing about patient education is just sometimes asking, what would you like to know? What would you like me to cover? I mean, we're trying to just say, aren't we? What does it say in this research paper? If you want to know what someone needs to or wants to know, it makes sense to just ask them, right? So at the end of every session, I always say to my patients, is there anything else you'd like to know? Is there anything I haven't covered? And the idea of that at the end, and I so often get something like, oh, is it okay if I do this? Or should I stop doing this? Or my last clinician said this. Is that correct? And it's never going to be something that I can cover, that I can, it's be literally like closing my eyes and throwing the bullseye. There is so much in people's heads that's unique to them. We are only probably ever going to cover it by giving them the space and the permission to come out and actually ask the question that's relevant to them. And can you believe how much value that might give someone? That they had their specific 10 other clinicians had just told them about pain or said, when you raise your arm, the shoulder does this and it impinges the tissue and that's why you've got shoulder pain. No, I didn't want to know that. What I want to know is, can I still go swimming? Or, I didn't want to know that. But every time I put my coat on, am I damaging my shoulder more? And it's just giving someone that space to find information that is relevant to them. And that may allow them to continue certain behaviours that they enjoy, that they value. It may allow them to understand and make sense of their problem, make it less fearful and less scary. It may allow them to keep doing things that other people have told them not to do. And those are really, really powerful. So for all of this information and education we discuss, the single most powerful question is always, is there anything I haven't covered? Is there something specific that you'd really like to know from me? And you often find the questions that come up are not what you would expect.
Yeah, I think there's so many ways to intersperse those type of questions throughout in an interaction, whether it's at the beginning. Before we dive in today, is there any immediate burning questions that you have for me that we can address? Or at the end, what other questions do you have? Is there anything else you wanted to discuss today? Any of those kind of just like you said, giving them space to ask the things that they need to ask or want to ask, and that's the most beneficial. And it's shocking how almost everyone will have something, or if they say, no, I feel like you answered them all, that's also a really good place to be.
Well, then don't you? And you've given that person the space to do it. But I promise you, when people say things like, oh, the primary reason people come to see a physio, for example, is pain relief, I don't actually believe that. I think pain relief is up there, but I also think understanding their problem is, well, there was the schmuck paper from 2022, and I think he was a physician. And they ranked in order of importance the reason why people sought primary care. And top was pain, about 1% underneath that was disability, and 1% underneath that was getting more information about the problem. Right? So again, we have information about lower back pain. What is the most important information about lower back pain? People want to know, is it something serious? Is there a serious pathology? Because they are worried that this back pain hasn't gone away. I had it for 2 days before. Now this has been going on for a week. There must be something serious here. Could this get worse? Blah, blah, blah. That is why they've come to see us. Not because they've got pain, but they've got pain and they've got worry. And they'd quite like both to go away. Right? But I reckon I'm better at getting rid of worry than I am at getting rid of back pain, if I'm being honest. Because I think the biology of pain in general sometimes isn't affected by manual therapy or exercise. There's much deeper systemic stuff often that goes on with more persistent pain. Things that aren't physical agents can't affect. But never underestimate the power of worry as a motivator for people to seek care. In fact, that was the Ferrara paper 2010 that looked at why do people seek care. Worry was quite high up in there. And that really is the point of education, is to minimise some of that worry, to minimise behaviour change from having pain, some of those negative factors. And I think if you're going to measure that by, does that change pain or not, then you're completely missing the point.
Well, I think that's a good place to stop. We covered quite a bit and touched on, I think, the really important things that people should be aware of during these interactions, and what are the really valuable kind of topics or bullet points or areas to hit on prognosis, reassurance, this kind of parameter of safety, knowing that connection is the biggest thing with all of that, and then being aware of the interaction and knowing how to go throughout this process, and that each patient is going to be a different scenario. And sometimes it's not going to be 100% because we're dealing with humans, and that's just the reality. But hitting the big take-home points, addressing their worries, addressing the big questions by asking open-ended questions, and not trying to dive into the nitty-gritty biology or explanations that aren't relevant to them or may not matter.
Yeah, I think you've hit the nail on the head. And I think the big one is, education is often static. It's information that we just throw at people. Making sense of a problem or knowledge coaching is dynamic. It's about two-way interaction. It's about humanness. So we need the information, but I think to make it resonate, to make it relevant, to make it actually have an effect on emotion and behavior, there has to be something more than just information. And I think behavior change research has shown that quite well. So if you're listening to this, the question you have to ask, why am I educating? What am I trying to do? Am I trying to have a positive effect on this human, or because someone on the internet told me that's the way that you treat MSK pain? And I think that's a really relevant point to make.
That's a perfect place to stop. Thanks for coming on for our second date, Ben. We'll link all your
Did you get me flowers is the question.
Yeah, they're being sent in the mail right now. You'll get them eventually.
Yeah.
We'll link all your information in the show notes. We always appreciate the information you put out with E3 and throughout all the avenues. So we'll call it there. Thank you again.
My pleasure.